Next, we're going to have Dr. Anikster from the Sheba Medical Center talking about novel metabolic pathways, paving the path towards targeted treatment.
So, thank you. My first time here. I'm like, how many? 17 years in the Tel Aviv University. I've never been here. I'm a clinician and hopefully a little bit research too. So I will try to tell you about two stories. One of them I understood that from the first lecture, everybody know what is PKU and hyperphenylalaninemia. So I will continue a little bit quickly on that. So PKU, it's more than, I think it's like 60 years already that they do NBS, newborn screening. Why they do for phenylketonuria? Because if you find it early, you can treat it. You have moderate, then and you have severe, and 1 or 2% of all the hyperphenylalaninemia are not because of the PAH, because of the gene and the enzyme that degrade phenylalanine to tyrosine, but because of the cofactor. So what you know and you heard about, it's the classical PKU, that most of them, 98%, it's PAH deficiency, phenylalanine hydroxylase, but you have a few that it's not, it's connection to the cofactor deficiency, many disease, different disease, and if you give BH4, you can improve it, it's logical. So that I think maybe I have 2 or 3 other pathways because I do biochemistry and genetics. So that's a classic phenylketonuria, and all the different enzymes that circle the biopterin cycle can cause hyperphenylalaninemia, but another disorders too, because it's cofactor to other hydroxylase. So for the next few minutes, remember that there is a 3 hydroxylase. We will be back to that in the end of this story. So the first story, so it's child health, and I see rare disease. That's the theme of the meeting here. So it will be both of them. It will be child and very rare, as you will see. So we have 2 siblings with highly consanguineous parents, Arab Muslims family. So maybe you know how you call this band? There is Arabic people, but that's called badal. It means it's 2 sisters that married 2 brothers, and their child married again. Okay, so it's very good economic and very good for genetics, but very bad for many of the disorders. So what both of them have hyperphenylalaninemia, it means increased phenylalanine, dystonia, movement problems, and intellectual disability. So as we know before, 60 years, people think that they know everything. They said, okay, it's unique BH4 problems. But what we can do, I think we are the only lab in the Middle East that can do it. We can take lumbar puncture, take the CSF, the material that circulates the brain, and can measure the bioamine, the neurotransmitters. The neurotransmitters can be from serotonin, dopamine, and noradrenaline. So if that's the end product of these 3 neurotransmitters. So if all of them are very, very low, like what I will show you in a minute, you think that these problems you have, MAO deficiency, it's only 1 family in the world, and it's totally different clinical. So we think that maybe we have different disorders that cause hyperphenylalaninemia, and it's maybe neurotransmitter deficiency disorders. So because everybody that I asked said no, we never saw something like that. Maybe you make a mistake, do it again. We decide, oops, something wrong here. I'm close to that. It's okay? So we decide to treat by the cofactor, by BH4. So here you see the boy and the girl, so that in age 13 and 12, and then you see that everything, like for example, the MHPG for certain, very, very low for adrenaline. So we gave BH4, we measure after a few years, you will see that it's almost, not almost, they are normal. So we have disease that we don't find mutation, it's not behave like PKU, but we treat with BH4 and it's help. So what you do now, in those days, you do to genomics. Yes, so it's very easy. We have, it's the time that we have whole exome. We did whole exome and we found a gene that nobody know what it is and in the beginning. That we know that it's connection with heat shock protein 17, we think that it may be connection with any problems of vesicles or what we called chaperone, and we have idea. We have a chaperone that cause maybe have the 3 hydroxylase and the BH4 stable these disorders. So if you find one family, you try to look for more. Then sometimes you have a lucky. So by chance, I don't know why they invite me to neurotransmitter disorder. I never have this new disease before. It's in very little island in Venice. It's 40 people. You cannot run away. And then everybody that I spoke with him in this meeting, I tell him, look, I have a new disease. I don't know. Nobody said, everybody said that. And one of them from Germany said, look, I think we have the same, but I don't know if we found the gene. To make long short, they have that our family, we have another 3 family, and all of them have different mutation besides the 2, so 3 different mutation, the same low 3 neurotransmitters, and we know that we have so-called new disease that have treatment. Then you know you need to prove it by quantitative PCR that our patients by Western, and then the connection that I told you about the DNJC12 and the 3 hydroxylase. Okay, what we do with that? We know that we have new disease after 60 years that people work. Sometimes you have new, don't close your eyes because somebody else, or all the expert, I was not expert in PKU. Now because of Udi Gazit and the people here, I suppose, no, I was not. But sometimes you have both lucky and so on, and you can treat it. And now, so it was 6 patients. After 1 year that we publish it, oops, I think now it's 6. Now it's 136 in the last year patients that have these disorders. Okay, so it's common that people know. That's the first thing, okay? A new disease that you can have treatment by chance. The other story, it's maybe rarer than the other one. So here you see a multiple affected consanguinity, again, Arab Muslim family, no dysmorphic. When we got the Propidus, the patients that we saw last year, we know already that there are 2 other affected with cardiac problems and no extra cardiac manifestation, only dilated, it means big heart, that not function. And one of them already passed in other hospital. So again, people check all what they know those days, it was 1 year ago, and found nothing. So we decide again to use genomics. So we do exome, what people today do trials, it means for the mother and the child that passed away. And it was, again, many genes that found homozygote, but only all the patients have the same mutation in the same gene. So what this PPCS gene do? When you have a Pantetheine or vitamin B5, you must have it to make coenzyme A. So coenzyme A, whatever disease you will work, you will touch coenzyme A because like 4% of the enzyme use coenzyme A for their activity because of the ATP. So it's Pantetheine, like vitamin B5, with ATP and with cysteine, like with sulfur, and that the 4 enzymes that make this coenzyme from A from vitamin B5. Before we found the PPCS, so other disease that if you have people that want to look for that, it will be nice. So we have 2 different disorders that connection with other team of this meeting. It's called neurodegeneration with iron accumulation. But we don't have any neurology manifestation in our patients. It means we have something unique. Only for after 2 minutes we will get for that we have material, we have a drug that you can buy out of the counter, like in every pharmacy, that bypass the PPCS. So the two diseases, they called neurodegeneration with brain iron accumulation, or NBIA. I'm sure that many people work here, and because it's called because of the MRI and CT radiology, it's called the tiger eye sign. All our patients don't have this accumulation in the brain. Okay? So why we need CoA? We said it's for 4% of the intracellular enzyme. The ratio of acetyl-CoA control protein acetylation and other stuff like death and autophagy. Why we have in the same pathway two diseases in neurodegeneration and the third one in cardiomyopathy? We can talk about energy of the brain and energy of the, we don't know yet. So again, we have one family, 4 patients, nobody presented in the world. What you do? Okay, so most of the people, it depends on your faith. If you have faith of human, you will go to gene matcher. If no, you will go to friends. That's the only way to know today, because gene matcher, you know, you put your gene, you never know who will see it in the other side, but we put it in gene matcher, no answer. Then you look for the pathway, and you look who the expert in the pathway. And we found Professor Odi Sibon. I wrote to her, she was very nice and told me, look, I will be happy to collaborate with you, but after 1 week he said, I'm sorry, I never told you, but I have another collaboration here that I collaborate with somebody in Germany. Or no one of you will work with me, or both will work with me, and that the agreement that we have. We work all together with people from Netherlands and Germany, and we found another family. That really was our sureness that we work in the new gene. It was different mutation, and she'll pass away in 3 months, and she have this morphic feature. So you can say that maybe more deleterious mutation, more severe phenotypes, I don't know yet. Okay, so big heart by MRI. So we check the vitamin B5, and it was normal. It means it's not bad. We check the protein level, Western, and all the two different families have low. We found that CoA, it's a little bit low. I know people can argue if it's right or no, that the CoA, it's really low in the fibroblast from patient. In the end, we will say that we need maybe more biochemical to say it again. And then, you remember, I told you that I bought, it's me myself, bought the Pantetheine from the out counter because we saw that maybe it will help. Still, you need, because it's human being, you must have approval from your institution. Until today, like 1 year or almost, the 2 live brothers that you remember from the pedigree get this medication, and they are stable. And that, again, thank you for all the people. You see, it's not a lot of people. Okay, so the take-home messages. So next generation genomics, you see, sometimes it's fun, sometimes you find, sometimes not, but still, we lack better understanding of the metabolomics of this and other inherited disorders. The field of metabolomics will shed a light for the pathomechanism. You know, you can do for every disease, you can do mouse, but it's not so easy to. And to pave the target treatment, and I hope that people here will stable the metabolomics, and from the next time we can show you for these 2 novel diseases, the metabolomics and not only the genomics. Thank you.
Thank you very much. It's a really interesting talk.
You're welcome.
It's really an interesting focus point about metabolites and how we perceive diseases in this post-genomic era that we are facing. Anybody have questions? So cell that have been affected.
That's the reason that we have so many students and so on to understand the mechanism. It's very important for me to say it's genomics. It's very tricky because sometimes it's very easy to get high ranked paper, but sometimes it's not help anybody besides academic maybe situation. So to do mechanism and to do pathway, it's very hard. So exactly like what you said, but that's the first clue. So a year ago, nobody know what it's DNAJC12, and nobody know what it's dilated cardiomyopathy. Now you can have and the easiest stuff to say is that you have for the family for the next pregnancy. They can check and not have this devastating disorder. So.
All right. Thank you very much.
Welcome.